I'm Lisa Orii, and on behalf of my colleagues, I am presenting our paper, HIV Client Perspectives on Digital Health in Malawi. Sub-Saharan Africa, where there are many low and middle-income countries, carries nearly 2/3 of global HIV infections. In these countries with high HIV incidence, eHealth systems are being increasingly integrated into healthcare settings to support comprehensive HIV care. eHealth systems are key tools for addressing challenges along the HIV care cascade, including testing, diagnosis, and adherence to antiretroviral therapy, or ART. Especially in HIV care, security and privacy are of utmost importance. eHealth systems contain sensitive information, and data exposure could leave people living with HIV to the face of stigma and discrimination. As adoption of eHealth systems gain momentum, consideration of HIV clients' preferences, perspectives, and experiences, including privacy concerns, should be prioritized. To give voice to clients' perspectives in a low and middle income country context, we investigated how HIV-positive clients on ART perceive data security and privacy in the context of electronic and mobile data collection. Our work takes place in Malawi, a country in sub-Saharan Africa with high HIV incidence. Our work addresses 3 research questions. First, how do ART clients receiving HIV care in Malawi consider privacy? Second, how do ART clients perceive the efforts of Malawi's health system to protect client privacy? Third, how do ART clients understand the processes involved in eHealth initiatives at Malawi's HIV care program, including digital data collection tools and data management? This work takes place in Malawi, where over 900,000 people live with HIV, which is approximately 8% of the adult population. Our work takes place at one of Malawi's largest public service delivery partners for HIV care, Lighthouse Trust, which is a registered public trust whose role is to support the Malawi Ministry of Health's HIV response. Lighthouse employs various data collection and data management tools. At its facilities, computers are used as access points to electronic medical records, and they're stationed at reception desks, vital signs stations, labs, exam rooms, and pharmacies. In 2016, Lighthouse introduced community-based care, or CBC, which is a nurse-led community-based ART program where clients who are registered at facilities can access services at community centers, such as churches, schools, and outdoor areas. At CBC settings, nurses collect client data using an offline, tablet-based application that operates in rural and low connectivity environments. CBC clients are familiar with computer-based data collection at the facilities and tablet-based data collection at CBC settings. At both facilities and CBC settings, clients bring portable paper-based health passport booklets. Each client is issued a unique barcode that is attached to the health passport. The barcode is scanned to access and enter client data. The health passport is used to check in clients for their appointments, and providers also write clients' health information in the passport. In our study, we consider how HIV clients perceive these 3 data collection and management tools used at the point of care with respect to the delivery of care. We conducted focus group discussions with HIV clients at Lighthouse from September to October 2022. Focus group discussions were conducted in clients' routine care settings, either at facilities or CBC settings, and in the local language of Chichewa. 8 total focus group discussions were conducted, 4 each at facilities and CBC settings, with 63 total participants. During the focus group discussions, we asked about information that participants share during appointments, how computers and tablets are used, participants' comfort levels with health information being collected and shared, and their mental models of data flow and management. We also provided an opportunity for participants to ask questions at the end. All focus group discussions were audio recorded with participants' consent. To analyze the data, we translated all transcriptions into English and applied deductive and inductive thematic analysis to code the transcripts. Meetings were held with the Lighthouse study team to fine-tune the themes, findings, and discussion points. we extracted 3 high-level themes. When explaining their discomfort with their data being accessed by individuals outside of the health system, participants referred to their fears of unintended disclosure of positive HIV status. To avoid having their status wrongfully exposed, some participants engaged in selective disclosure, in which they consider which people to disclose to, as well as the environment if the people will be able to maintain confidentiality. However, participants were not concerned about the consequences of data being shared within the HIV community. Disclosure was viewed as a critical experience that can encourage people living with HIV, or PLHIV, to take care of their own health and also help oneself with improving health management. One participant said, "I was comfortable disclosing to everyone because if I am to keep it to myself, I would have died by now. Because when you disclose to someone about your status, they tend to share with you some other ideas. You also motivate others who come and ask how you manage to open up. But when I open up and shared about my status, I noted that some of them became comfortable and asked me how I take care of myself so that they can do the same." At the same time, participants understood the importance of protecting fellow PLHIV from discrimination and stigma and not revealing anyone's status. After informing participants about the Ministry of Health's policy to require local data hosting for local partner digital health implementations, participants responded optimistically, saying that the policy protects clients. HIV clients are willing to contribute their data so that the Ministry of Health can acquire funding that sustains Malawi's HIV response. At the same time, participants were firm in their belief that data shared publicly should only be aggregate data that makes known the issue that the people are facing and not the person. Participants trusted that Lighthouse staff, especially healthcare providers, execute their day-to-day work in a manner that respects and protects clients' privacy. Participants' confidence in their providers stemmed from their trust that providers have never broken confidentiality. Participants recognized the value of having computers and tablets in their care and were able to explain how they carry health information and help inform providers' decision-making. Participants appreciated that computers and tablets were used with the health passports so that clients can keep a record of their own information while having the information securely stored in the devices. However, participants also wanted a layperson's explanation of their health so that they know how to manage their own health. Participants had a clear notion of who data should and should not be shared with, even within the Lighthouse staff. Participants agreed that client data should not be shared with non-medically trained personnel at Lighthouse, such as cleaners, guards, accountants, and other clients. Although these groups cannot access client data, participants were concerned about being seen walking in and out of Lighthouse, which is a widely known provider of ART services. Through personal experiences, participants made sense of the data flow in the continuum of care. CBC clients had a good idea of how data was managed and stored based on their observations of computers at the facilities. Participants also recognized the similarity between the tablets and personal mobile phones. One participant described the way data is transferred from the tablet to the computer as the way we do with our phones, by forwarding the information like a message. However, uncertainty about how computers and tablets were used remained. Participants said that there is little direct communication from the providers on how devices are used and that there is no way for clients to confirm whether providers are correctly recording appointment-related content. One participant said, "What we know is that the provider documents for us. Whether they write what we told them or not, we don't know." We now summarize our findings and answer our research questions. Our work contributes a broader view of privacy held by PLHIV in the healthcare context and beyond, that centers around the influences and impacts of disclosure-related decisions and concerns. PLHIV took control of their disclosure processes by practicing selective disclosure to minimize the chances of unintended disclosure. Within the HIV community, PLHIV disclosed comfortably to gain and encourage communal and medical support, and respected other PLHIV's approaches to disclosure. Participants believe that data privacy and data sharing are compatible with one another, given that there are security assurances. PLHIV's interests in contributing the data for HIV program assessment and global ART funding stem from their trust in Malawi's health system to protect client confidentiality. We deduce that clients' trust in data sharing derives from their trust in national privacy protection efforts and healthcare providers. Participants' understanding of and acceptance of tablets used in CBC illustrates an increased familiarity with digital systems in healthcare contexts and mobile devices at large. At the same time, some participants were uncertain about how devices were used, especially outside of appointments, calling for continued efforts to inform clients of device purpose and security. As participants acknowledged, technologies do not function alone. Providers and Lighthouse as a whole must continue to prioritize clients' needs in terms of privacy and quality of care. In CBC settings, the expansion of tablet-based care likely stemmed from prior positive exposure to digital data collection at Lighthouse's facilities, allowing tablet adoption to be accomplished without creating friction or opposition from clients. Lighthouse offers an example of successful integration of mobile devices in healthcare, contrary to many mobile device-based health projects in low and middle-income countries. Lastly, we provide the following recommendations for building strong digital health systems in low and middle-income countries, while advocating for continued consideration of clients' voices. First, clients should be communicated about their data and how it is used in accessible, non-technical language. Providers should use devices at the point of care to facilitate interactive conversations, not for one-way documentation. Clients should also be educated about the differences between aggregate data and client-level data and their implications for privacy. Second, the health system should leverage clients' familiarity with technology to enhance the acceptability of devices used in care. Clients' experiences and perspectives should be at the center of technology development and adoption efforts. There should be continuous efforts to enhance client familiarity even after technology adoption by providing clear explanations of the technology's purposes and clarifying the technology's value. Third, technology should be secure beyond client expectations by meeting global security standards. Clients' trust in the health system urges a call to action to ensure that technical security is competently built, assessed, strengthened, and sustained by professionals. Here are our takeaways. PL-HIV have a broad privacy framework that impacts their decisions around disclosure, where to seek care, and adhering to ART. Focusing on clients' data privacy perspectives and priorities is critical for enhancing security and confidence in digital health systems. Health systems should continue to make efforts to ensure that digital health systems are robust and secure. Thank you for listening.